So I'm Julia Adler Milstein. I'm a chief of Doc IT, our division of clinical informatics and digital transformation that you heard a bit about this morning. I am thrilled to have been given the opportunity to organize the health systems track and this panel this morning. What I really wanted to do was to bring examples and voices of those who are leading AI implementations across our 3 health system settings to be able to give you a sense of the guts of that work. How do we actually implement AI tools? You heard this morning from Sarah Murray about some of the infrastructure that we have put in place and processes to support that, but now you get to talk to the people who've actually worked with that to understand what that experience has been like. So each of them is going to come up and describe a particular project for 8-ish or so minutes. If there are any then critical questions about that particular project, we'll just do some like short Q&A after each one. But then my goal is to have an hour at the end where we can ask broader discussion questions across all the panelists so we can really understand sort of at a system level where are the opportunities to do this work, particularly at the next level of scale, because I can predict one of the things they'll tell you is that this work has been extremely hard. And if we're going to get to a future state where we can rapidly integrate AI tools into health systems, we have to figure out how to build, again, the infrastructure and processes to be able to do this more rapidly and with less blood, sweat, and tears. But today you'll hear about the blood, sweat, and tears. And so we're going to go in. Well, anyway, I'll call you up if we're not sure about the order, but we are going to start with Hossein Solemani, who's going to tell us about his work on predicting no-shows.
Thanks for the invitation. My name is Hossein Solemani. I'm Director of Data Science AI in the health system. I am a computer scientist engineer by training. In a sense, it makes sense for me to do these kind of things. Perhaps maybe not the clinical domain is the most obvious thing, but it makes sense for me to do AI things. This particular project that I'm going to talk about, it was a collaboration with faculty from DGIM, General Internal Medicine. It was a Caring Wisely project a couple of years ago, trying to predict patients who are at high risk of not showing up for their clinic appointments, with the idea of doing some kind of interventions to help them show up and make better use of those slots. All right, so as I mentioned, this is a project talking about predicting no-shows in clinic. So the problem was that in some of UCSF clinics, the no-show rate exceeds what's typically known as industry standard of around 5%. This has implications for patients, obviously. It may exacerbate problems that patients have in terms of access to care. It disrupts productivity for the providers, for the clinic staff, and also it's a revenue loss for UCSF. So there's broad interest to help reduce these no-shows. Our team did a survey of patients who no-showed at a primary care clinic at UCSF. And interestingly, around 45% of them said that they were not aware that they had an appointment. No-shows generally are very complicated. People not show up for their appointments for many different reasons. In particular, around not being aware of their appointment, one thing that stands out is that at the time, especially, the automatic text reminders that patients receive about their appointments is only available in English. So that's more problematic for patients whose preferred language is not English, LEP patients. Other reasons that were brought up in this survey was feeling too ill to show up, insurance reasons, transportation issues, and family or work obligations. At the time, beyond the automatic text reminders that people received, generally the intervention was overbooking those slots that patients are very high risk for not showing up. But what was obvious after this survey especially was that there is a need for personalized interventions. Different interventions may work for different people, and in particular, one thing that we started with was manual outreach calls that clinic staff would do. Focus on LEP patients, but also then later extended for all patients. Other interventions we discussed, but didn't really implement, which we can talk about later, was providing taxi vouchers for patients and conversion to telehealth. That was also one of the things that was brought up in the survey, that people are actually open to that if it is clinically appropriate. So we built a model using like 90-something different data points from a history of 1 year appointments, history of 1 year leading to the current appointment, making a prediction about the risk. A couple of nuances about like setting tuning the model. We talked a lot with the clinic staff to see what's the bandwidth of doing interventions. So it was like 30 calls per day. So that's how we set the model to alert that many appointments, to flag that many appointments per day. We also talked about and thought carefully about fairness and ethics. So what does it mean to be fair in this case? Because our interventions were going to be around helping people to show up for their appointments, calling patients reminders and so on, we settled on setting the sensitivity of the model to be the same across different race ethnicity groups, with the idea of different groups benefiting somewhat similarly from this intervention. And the model was deployed using HiPAC. I put a link here. We can talk about that later. With any AI tool, it's very important to think about intervention. So we built also a bunch of different dashboards, track different metrics, looking at no-show rates, KPIs, breakdown by race, ethnicity, language, age. We also tracked calls that staff made to make sure that there's no disparity between different languages, for example. And if we saw something, we could intervene. And we also tracked who are the staff that are making the call, and we provided this data to clinic managers to help manage the interventions. We looked at the impact of this. We did what's called a difference in difference analysis. We did this pilot in one of the primary care clinics, and we looked at the before and after intervention period at that clinic and compared it with other primary care clinics, with the idea that if there is any change beyond what the trend that we see in the other clinics, this is probably a result of our intervention. So we saw actually a 50-something% reduction in no-show rate among LEP patients and 25% in all patients. One of the challenges I would highlight is that there was no dedicated resources to this intervention. So these are clinic staff who are already busy doing other things. They were very good at participating and following the interventions during the pilot program, but after the pilot, they were busy. They went back to their otherwise busy jobs and did other things. There was not really, at the time, the priorities for the institution was something different. So this was, there was not enough interest to scale this beyond that clinic. Recently, there's renewed interest to talk about scaling this to other clinics. So we'll see. A few points I will summarize at the end is that kind of an obvious thing, but sometimes people forget, is that AI by itself doesn't do anything. It's the intervention that matters. Even if you have the best model in the world, unless there's someone who's acting upon it, that it's not going to change anything. And that requires also operational ownership from the clinics or whoever the people are that need to act on the model. In terms of thinking about the UI and how do you present this prediction to the end users, sometimes people think about predicting just the risk. So we say like low risk, medium risk, high risk, versus providing a specific interventions or steps that people need to take. What we saw was that an earlier version of this model only provided risk categories. And it sort of leaves it for users to decide what is appropriate. And something that's kind of organically emerged was that, well, high-risk patients, they're going to no-show regardless of what we do, even if we call them. So let's focus on medium-risk patients, and we just double book those slides that are for high-risk patients, which may or may not be true for some patients, but it exacerbates, if you do it systematically, the access to care. The last point I would say is about fairness. As I mentioned, we looked at sensitivity across race ethnicity groups as a way of defining fairness. That obviously depends on the intervention. So what people are going to do with your model determines how you define fairness. If, for example, if our intervention was going to be, we're going to double book those slots, then that's kind of a punitive intervention. So we want the model to be very accurate and false positive rates to be perhaps the same. Versus if your intervention is to help people show up, that's a different scenario. So thinking about the intervention from early steps, that will help also define what fairness would mean. And I think that's my last slide. Thank you.
Okay, under time, use the slide template. You set a high bar, Hossein. So we have time for if there are one or two just quick sort of clarification questions for Hossein. Anything critical? Tomoko? Yeah, if you don't mind going to the mic just for the recording purposes, there's 2 mics.
Great presentation, thank you. I just wanted to ask, among the 90 features that you used for your prediction model, which ones appeared to be the most contributing to the success of your model performance?
So no-show is complicated. A lot of the reasons that people will not show up for their appointments is not even in the EHR. Like if it's raining or if I have something at home. Because of that, it's very difficult to actually make an accurate predictions. What is most predictive among the data that we have is actually the history of appointments. When did you show up? When did you miss your appointments? Is there pattern in like time of day of week, type of providers? Those tend to be most predictive.
Thank you.
Okay, I think we will transition to our second speaker.
Thank you.
Thank you so much, Hossein. All right, and I think the slides will be up in a minute. So Priya, maybe just start off by telling us how you got into this work.
Yeah. Hi, good morning, everyone. My name is Priya Ramaswamy. Today I'm going to be talking about Smart Match to optimize perioperative blood transfusions. So just a short raise of hands, how many of you have ever donated blood or know someone who's received blood? Good, raise them high, good. So like a lot of people in the room, great. So what's the problem that I and my team are trying to solve? So currently UCSF has a antiquated system called MSBOS, which basically is the maximum surgical blood ordering schedule for patients undergoing surgery at UCSF. And it tells the clinicians and the blood bank who they think would need preoperative blood testing or blood matched for them. The problem with this system, it was developed in the 1970s by a couple of surgeons somewhere else in the US. It lacks patient factors, so it only is based on the type of surgery they're getting, but no other patient factors. It's not trustworthy. Many of our pre-op clinicians and nurse practitioners who work in a preoperative testing, whatever it recommends, they end up not doing it because they, use reasoning to figure out who needs preoperative blood work testing. And there's no recommendations for other types of blood products like fresh frozen plasma or platelets, which is part of like whole blood. And additionally, looking at data from UCSF, and working the operating rooms, we realized that there was a lot of unnecessary pre-op tests ordered. So to match a unit of blood, you would need what's called a type and screen to see what type of blood a person has, a check specimen, which confirms their type of blood they have, so like A, B, O, etc. And so a lot of those were ordered unnecessarily. And we also realized that a lot of the blood was actually being wasted, both red blood cells and FFP, monthly at UCSF. And there's a couple of reasons for this. One is whenever a product like FFP, fresh frozen plasma, is ordered, it has a 5-day shelf life. So once you thaw it from frozen, it has to be transfused within 5 days or it goes to waste. And if you can imagine, we do thousands of surgeries each month at UCSF. And if we think a person needs blood, we'll request these blood products. The blood bank will have to thaw them, get them prepared. And if they don't get used and they can't find another person to use it within that time period of expiration, then it goes to waste. And so that results in not just product waste, but also operational waste, because to match a unit of blood, it takes a lot of human power hours to do all the testing to make sure that we transfuse the appropriate blood for each person. So what was the solution? We wanted to optimize blood preparation for our patients that need it, while also reducing unnecessary blood testing and preparation for those patients that don't need it. And so our goal was to develop an EHR tool to help staff be more aware of a patient's blood product needs prior to surgery using machine learning. So what UCSF AI infrastructure was involved? I would say a lot of infrastructure was involved. We used a team that Hossein works at called HiPAC under Sarah Murray's team, the AI governance committee that, we regularly checks in on our work, CTSI, the Learning Health System, Apex-enabled research program, which is helping us design the intervention that clinicians would ultimately see in the EHR. The research analytics environment, which is the computing environment to do research at UCSF, a plethora of UCSF AI and research experts and also clinical experts, and then several grants that I received, the AI Pilot Award in 2022, and then an anesthesia department seed grant. So what's the current state of the project? So the AI Pilot Award was received in 2022, and then 2023 to 2024, we actually developed the model and then did a first round of just red blood cell silent validation, which was completed, which showed that our initial model does outperform clinicians, not only like a week before surgery, but up till the time the patient is in the room. And right now, we just developed a multi-product model, which recommends RBC and FFP and also platelets. So we just finished that model building, and we're hoping to launch a silent study, hopefully by the end of this month, with the HiPAC team. We've been working on the user interface for quite a while now, and once the silent validation is done with the multi-product model, we'll just update it for FFP and possibly platelet. And then ideally, hopefully by the end of this year, fall, summer or fall, we will want to do a live prospective randomized control trial to show clinicians our recommendations. So what has been the hardest part of the project? Really, it's model building in real life takes time. The easy part was developing model retrospectively, but then putting it into prospective production, it actually made us go back and reevaluate and redesign our model multiple times. Part of it being data availability, data timing. And so when you have to think about models that are running real time, for us, one thing I realized is that data flows in the EHR at different times. For every patient encounter, they have an updated lab test or updated clinical diagnosis, and so we have to capture all of that. End user experience, we really have thought about how would clinicians feel having an AI system tell them what to do preoperatively, and then making continual refinements has taken time. What advice do I have for others seeking to study AI use in a real-world clinical setting? I would say choose the right problem to tackle. The reason I chose this problem was because in 2022, the American Red Cross in early 2022 actually announced like a national shortage of blood. And then working in the operating rooms as a fellow at UCSF, I just realized that I myself am ordering sometimes unnecessary type-in screens or like blood that ends up never getting used. So definitely when you're applying to do an AI clinical project, definitely it's nice to have real world experience and like identify the problem at bedside. And then really take time to plan things out and be flexible. And then definitely collaborate. I think I wouldn't have been able to do this project without the help that I've received. Like I said, I have a ton of people that I want to thank, but I don't want to take up too much time. But some of these people are on the panel today, Hossein and Andrew Bishara, and then many of them are in the audience today. So thank you so much. I look forward to talking with you later.
Okay. Any quick questions for Priya? Yeah. If you don't mind, you have a microphone right behind you. Perfect.
Hi, my name is Maria. I am the nurse scientist in the health system, and I'm just so excited for this project because it has so many clinical implications. And my question, maybe not now, but in the future, are you planning to do like an ROI, like economic evaluation of how much money you spend, like saving the blood versus how much money it took to like build a system like this? Because I think that would be very compelling to operational leaders to say, yes, we're going to like invest resources in sustaining this kind of work.
Yeah, so there's a couple of things we can do to measure that. So one, every blood test that's ordered for a patient does get billed to their insurance. So you technically can save the patient side money. But we can also measure like product waste, and then it's not just the test, but you can think of like the number of hours that it goes to sampling and testing these products in the lab. So we have some ideas up our sleeve on how to measure that. So that's to be done. I'm going to hand it off to the next speaker. Thanks.
Hi, everyone. My name's Andrew. I'm an anesthesiologist also. And this is another surgical project. And just to give you an idea of how long this process takes, I actually started this project in like 2018. And so it's still building. We're on the prospective validation, but really excited about it moving forward and us finally being able to use it. And a little background on it. So the problem to be solved is that post-operative kidney injury is actually more common than you might think. In the cohort we're looking at, it's about 10%. So you go into surgery, you potentially think you're fine, and then could get kidney injury. And it's a really well-described problem. It's known to be costly and dangerous, prolongs length of stay, increases the chance of chronic kidney injury, mortality, heart attacks. And there are known preventative interventions that are pretty agreed upon. One of the biggest ones is reducing the number of minutes a patient has low blood pressure during surgery. And the gap is that we actually underpredict it as physicians. So this is the perfect gap for machine learning. So we kind of found that quite a while back and decided to build a model that predicted before surgery and during surgery every 15 minutes to try to notify the providers which patients are at high risk for kidney injury. And then at that point, it's clear what to do, but we kind of leave it up to them. Like, you want to reduce the number of minutes of low blood pressure, but how you do that, do you reduce the anesthetic? Do you increase the blood pressure using pressors? We leave that up to the providers. And we're looking now into using reinforcement learning to provide those recommendations. But right now, these models are just to notify those patients and fill in that gap. So I'll touch more on the model, but the teams that we've worked with have been just amazing. And many of the groups have already been mentioned, and people have come up, like Hossein, who's on HiPAC. There's the HiPAC AER teams, AI oversight. So both of our models went through initial approval by the AI oversight committee. Some work with Versa on development. RAE is not mentioned here. The Learning Health Systems is helping us set this up to be a randomized control trial. Faculty collaborators and mentors have been amazing as well. So the current state of the project, we completed retrospective validation. And like Priya said, there's been a lot of bouncing up and down between these steps, but that has gone well and has compared with a lot of the other models that did better than clinicians in the past. AI oversight completed for both the preoperative and intraoperative model. The design of the EPIC interface has been drafted but not built into EPIC yet. So you can see on the left there, the pre-op model, and it actually provides some interpretation so the clinicians can kind of decide, like I would want to know whether I agree with this model. So knowing the background of what the model's putting weight on is helpful to decide, I don't think the model's right here, or, oh, I didn't think about that. And then the intra-op model's on the right. And the beauty of that is it actually trends the risk. So if you are making interventions and you're seeing the risk go down, that's good feedback. If you're seeing it go up, maybe you want to change your view, but we're not including that as part of the recommendation. That is just the clinician responding. And then prospective validation is currently going on, and that's super important because we actually found our performance dropped and we weren't sure why. And so we actually found there were some variables missing, so we had to tweak our model and some of our data collection. And then RCT would be to randomize patients to receiving this model or not receiving it, having a blank screen, and then hopefully reducing the number of minutes that the patient has low blood pressure would be our outcome. Eventually, we would want to drop kidney injury as well, but that may be a little far to start with. So what has been the hardest part of this project? I would say for me, it was difficulty deciding when the model's good enough and not trying to make it better so that we could halt and move into prospective validation. And then also estimating timeline. So I have a grant for this from the NIH, and deciding how much we're spending each year is really important, making sure we're spending enough, but not too much. And estimating those timelines can be really difficult. So advice I would have is really know your workflows, know your environment. It's helpful to work in the environment that you're wanting to recommend. Go beyond the model. Like Priya said, just having a retrospective model's not enough. And Hossein said the intervention is what matters. And so think about if your model were perfect, what your intervention would be accordingly. And then really clarify that success as a result. So if your intervention did a good job, what would it look like quantitatively? And then really assemble the right team. Initially, I kind of started this by myself, now building up a team, but I wish I had that team before because it's quite a bit to have to continuously respond to the teams you're working with, rebuild the models. It's a lot of programming. So that's been great. And a lot of people to acknowledge for this project, including my funding. Thank you.
All right. Well, we've made it to the halfway mark in our presentation. So Luke, I think you're up next.
I'm Luke Zier. I'm an interventional cardiologist at UCSF, primarily practicing at ZSFG. I'm also part of Doc IT, and I currently direct the ZSFG Prospect Lab, which is essentially the predictive and prescriptive analytics lab out of the Continuous Performance Improvement Office at ZSFG. So the initial challenge that we were asked to address was actually related to hospital-related readmissions. Safety net hospitals, as is true of most hospitals, are measured based on their readmission metrics. But safety net hospitals in particular have a lot of at-risk funding if they're unable to meet performance metrics. And if you're unable to meet those performance metrics, then that means a lot of lost dollars that goes directly to clinical care. So as we evaluated this problem initially, what we realized was that 40% of our readmissions were due to heart failure patients. And so as we dug into that further, we realized that our readmissions were reflective of suboptimal clinical outcomes. So we had elevated mortality rates when we compared our heart failure population compared to peer safety net hospitals. We also had a lot of inequities in care, particularly our Black African American patients with heart failure when compared to our general population. And so we had really three main challenges. It was to attempt to reduce readmissions while also improving clinical outcomes and not worsen inequities. So how did we address this? Well, we started addressing this by developing a readmission prediction model. I will candidly say that we did evaluate some proprietary models. Those models performed very, very poorly in our health system, and so the decision was made to develop our own model. This is a gradient boosted tree, and you can see some of the performance characteristics here. I will say that this model initially started with over 3,500 features, but due to our deployment platform, which I'll talk about in a moment, we ended up having to reduce that to 42 features. While this model is necessary as a solution, it is not sufficient. So we spent a lot of time then thinking about how to deploy this model across the health system, and we deployed it in several different ways, including at the point of care and also as a population health management tool. But just to give an example of how we deployed this, so this is a decision support ecosystem that we created within the electronic health record. So we created a custom navigator within Epic. And through that custom navigator, we were able to surface various decision support to end users. So here you can see inline decision support prompts that give information both in the medical and to some degree the social domain, describing, that a patient, for example, needs a follow-up appointment in cardiology clinic and their volume status. We also created a checklist so providers could see where the patient was along their treatment course, and the checklist and the inline decision support adapted to each individual patient based on their individual needs and where they were in their hospitalization, and also across the continuum of care during their hospitalization. And then here you can see how we actually surfaced the prediction model. And I think, as Hossein mentioned, which I totally agree, a model prediction in and of itself is not going to change practice. So we linked the prediction to actionable tasks that a provider could take. In this example, it's providing this individual patient who's at high risk of readmission with a prioritized referral to a heart failure specialist in our clinic. So this has been deployed. We have outcomes, which we actually just published last week. So in terms of our mortality, so we saw a significant reduction in mortality in our post-intervention cohorts. In terms of racial disparities, so you can see as of 2018, we had quite a significant gap between our Black African American heart failure patients in terms of their readmission rate compared to our general population. And as of 2022, we were able to actually invert that gap, and that's persisted into the current state. This is our actual readmissions trend. This is interrupted time series analysis. So you can see our readmissions were trending up. And then when we implemented, we saw a significant decline in our readmissions. And so we went from a peak readmission rate of 33.3%, which was candidly the worst readmission rate among safety net hospitals in California. And now we are the lowest or one of the lowest, kind of depending on the month that you look at. And then in terms of return on investment, because we were able to meet readmission metrics For the 6 years after this has been deployed, we've been able to save the health system $1.2 million in at-risk funding. So it took us about $1 million to develop and deploy this. This is not like a full comprehensive, cost-benefit analysis, but approximately the return on investment for the health system has been about 7.2 to 1. In terms of the AI structure that was utilized, so again, this was deployed at DPH and in ZSFG, so this is slightly different. In terms of data extraction and data set development, so we used our Maggie team, which is an internal data analytics team at ZSFG, and that was subsequently transferred over to ARS at UCSF. Our model training and testing, which was originally done through Winton, because of some challenges that we had with Winton, was this transitioned over to GPUs at AWS through UCSF Ray. Our model deployment was done through Epic Nebula, which can be quite constraining in terms of the numbers of features that you can include in the model. And so hence my initial comment about our need to reduce the number of features that were included, and we lost some performance. And then our EHR integration and point of care decision support architecture build. So we do not have Apex-enabled research at ZSFG, and so we actually had to utilize an outside consultant that was effectively hired into my lab, but was a ZSFG DPH employee. And approval and oversight was done through various DPH, ZSFG, IT, and executive committees. So what were the challenges and advice for studying AI use in real-world clinical settings? So as I see it, I think there are challenges at the beginning and challenges at the end. So starting at the beginning, so I think this project is probably more reflective of a little bit more of a kind of real-world community hospital setting where there's a lot of competing health system priorities. And the financial environment right now is not particularly favorable, and IT resources are constrained. And I think as we as researchers think about the realities of the funding environment, one important, I think, piece of advice is to align projects with health systems priorities and KPIs. So this was a clear KPI for the health system, so they were willing to invest in it. And we had a lot of support as a result of that. I think also defining measurable outcomes and clear return on investment. So we knew what we had to deliver on. We knew what the ROI needed to be, and we could explain that to the health system leadership in terms of what we were able to do. And then also developing a regular reporting plan to health system leaders. So, regular meetings with executive leadership and project liaisons, because those are the people that are going to break down barriers and help to facilitate these projects forward, because inevitably there will be challenges that come up along the project. And then I think the other challenge is deployment. I would say we thought as much about deployment as we did about the model itself, if not quite a bit more. Model development is just the first step. You need to consider how the model is going to surface information, how it's going to interact with end users, how it's going to integrate within the clinical ecosystem. Because you can develop a fantastic model, but if nobody uses it, then it's not going to have the intended impact that you want. For us, deployment is not a one-time task. It is an ongoing dynamic process. We account for factors as varied as the changing model performance, rotating end users. So for example, this has been deployed now for several years. We still meet with our residents on a monthly basis to orient them to this tool and to explain to them how to use it. So it's an ongoing deployment process. And then I think what was helpful to us was to utilize an existing deployment framework. We use both a lean framework and also an implementation science framework. But I would also say that personally, my thoughts are that we probably need some new frameworks to think about how we integrate technology and deploy at scale in various health systems. And so hopefully those will come along in the future. So thanks so much for letting me present.
Any questions? Yep, I see.
Hey, I love this. I really like the management checklist that you implemented. And I'm wondering if you have looked at which of the actions affect you, or do you have a hypothesis about which of the actions affected the change? Because it's like a bundle, right? But which one or several matter the most?
It's a good question. So in terms of our outcomes, so we know that, for example, our rates of guideline-directed medical therapy prescription went up substantially. We have a presentation at the American College of Cardiology that we're presenting next month to demonstrate that. So we definitely had improvement in prescription of medical therapy. We also had much greater linkages in our high-risk patients to our heart failure clinics because of those prioritized referrals. And also what I didn't show here is particularly some of the what we tried to do in the social behavioral domain. So we had a lot of success actually linking patients who had heart failure and were actively using substances to clinical resources. So we think a combination of those things led to the improvement. But to be clear, it was not just the model. The model in isolation would not have accomplished the effect that we saw.
All right, why don't we take one more question over here?
Sorry, I might have missed this during your presentation, but what exactly was the timeline of events that happened? Like when did you invite the outside consultant to join your team? When did this deployment start at all? Like, et cetera?
Yeah, so we initially started working on this project as far back as 2017. Actually, our initial pilots in this area were paper-based, like discharge checklists. That subsequently evolved. We had an Epic implementation in 2019. That subsequently evolved into building a data science team and transitioning the paper-based checklist into that adaptive EHR-based tool, and then development of a model like around 2020 that we eventually deployed. So probably more time. We need more time to go through the entire timeline, but the inception of the project was 2017, and then it's continued to be in deployment since about 2020.
Okay, so that means that the digitization happened before the model was actually established.
We deployed them simultaneously.
Okay.
Yeah. So it was like a bundle that was deployed together. Yeah.
Great. All right. Thanks, Luke. And we will welcome up Adam.
I'm Adam Yala. I'm an assistant professor in computational vision health, both here at UCSF and Berkeley. And it's an honor to share something about our work today. Everything I'm going to show you today is joint work with Maggie Chung, who fortunately can't be here today because she's working on our other trial right now at a separate regulatory meeting, which is a foreshadowing with the rest of the talk. So what did we do and what are we trying to solve? So this is a workflow modification study. We're looking at how can we make the experience of resolving a patient mammogram better for the health system and better for the patient. So to give you a sense of what is the workflow today, if someone has a suspicious finding, what we call a bio-rad 0 in the screening mammogram, you have to get, these are originally read in batches, so not in real time. You have to schedule a diagnostic mammogram afterwards to kind of investigate what's going on, kind of go along the diagnostic workflow. This setup is usually a week to 6 weeks after the initial screening mammogram. As you might imagine, patients can be quite anxious in those 1 to 6 weeks waiting to get this resolved. And at SFGH, about a quarter of these diagnostic exams actually have no-shows, which causes its own kind of difficulty to the health system in making this workflow efficient. And so the fix here is, there we go. It's quite simple. Across my work, I've built a lot of AI models for cancer generally, and especially breast cancer. We have AI risk models, and we deployed my previously developed AI risk model in real time to the clinic. So as people get screening mammograms, within seconds, we have risk assessments. This means before the person walks out the room, we actually know how likely they have to have cancer right now. We refer the highest risk subsets, the top 10% risk, to get a same-day read. And we invite patients to consent to this workflow. And if they do, and if they're high risk, they'll get a same time, same day diagnostic setup. And off of this kind of top 10% risk, we expect the sensitivity to be roughly 60%. So more than half of the cancers we expect to see at all will be benefiting from the same day workflow. So that's the setup. And to give a little bit of context, what's the model? It's this thing I called Mirai. I built back from my PhD, originally validated it at MGH. It worked in a separate paper at 7 hospitals. We're currently at about 66 hospitals across 30 countries where we've tested the model. So we've done a lot of validation before getting to this point. Now to dive into what validation specifically did we do to enable this study and our new work at UCSF. First, we work in pulling together all the breast imaging data we have access to at both UCSF and SFGH. So it required kind of 2 key tools, both supported by radiology. One, Empower, it's a nuanced product to kind of pull together radiology reports. Actually built a scraper to make that less painful, but we have lots of those. We used the AIR API to download the retrospective mammograms to kind of test our models in hindsight. To go from reports to outcomes to understand how well are we actually doing, because all this is kind of in free text. We built a tool for kind of fine-tuning open source LLMs to get to like version-controlled hemoglobin performance. That's called Strata, and if folks are interested, that's available, and that's a few other labs at UCSF are not using it. And then to actually run the experiments, to run the old AI models, and to also build all of our new ones, we used resources at FAC with our own GPU servers, and there'll be many thank yous and shout outs within this short presentation, but one of them is the FAC because they've really made our resource life possible, and I'll do many more thank yous in the minutes to come. Okay, so that isn't kind of retrospective validation. Pull the data, lots of really great resources for that. ran the model, make sure the performance is what we expect in line with all the other 60 plus hospitals we've worked with. So we know kind of where the performance profile should be, and we can pick the threshold that makes sense. To integrate the risk model to have real-time risk assessments was actually also fairly straightforward. So this took really great partnerships with the SFGH IT office. Shout out to Omar. I visited his office, bought a computer, loaded all the UCSF security tools, and just gave it to him. We have the current setup is as people get screened, DICOMs, the kind of medical image format, is generated. They're forwarded to PACS. That's standard. There's a PACS rule that Omar set up to forward any new screening mammograms over to our machine. I wrote code to kind of take that, to get the risk assessments, push that to RedCap in real time. And if someone's high risk, our wonderful CRC, Eric Davis, gets an email. And so does our study team saying, risk assessment for this person at this time, now we're ready to kind of move on the study workflow. This step was actually quite straightforward. And to give you a sense of project status, we're about almost halfway through our enrollment goal, 45%. 2 to 3 days per week, depending on who's working that day. We offer this workflow to patients. And I think it's clear to say that patients are interested in this because our enrollment rate is 100%. We've gotten a lot of anecdotes of like a positive patient experience who are appreciative of having the ability to have a same-day evaluation, not having to wait for weeks of like, maybe you have something, maybe you don't. And this saves a lot of repeat visits, which is especially important for patients who don't want to take off work several times and have like difficulty traveling to SFGH. And on the radiologist side, we've gotten a lot of feedback that this is a pretty seamless experience. There's no manual steps, and the kind of transition between the screening and the diagnostic process is fairly efficient, and it has its own kind of workflow efficiencies. And so we can say it's smooth sailing, things are going well. It's too early to read out results, but things are kind of coming together. So you might imagine, well, what was the hard part, right? Because as Julia mentioned, there's blood, sweat, and tears in every one of these projects. For us, the hard part was getting started. It was a little bit baffling when we stepped back to kind of review how long it has taken for us to get here. So we had the AI tools already. The validation was pretty quick. Regulatory approvals to kind of from proposing the study to getting started was about 13 months with 17 separate sign-offs to kind of really go over lots of very overlapping information. The technical integration, once we had all those approvals, was pretty straightforward. Matrons with Omar, things were great. And the study itself is expected to only be 9 months, and that's been fairly smooth. So by far the hardest part was maneuvering the regulatory process in the many overlapping committees, and many of which are sequential in nature. So what is my kind of advice in kind of doing studies like this and others? I really think it's fair to say it takes a village. There's many people, both our mentors and like who helped us maneuver this process. This is our first time going through this. But also working with the various teams that kind of host the kind of key technologies. I want to thank the folks at SFGH IT who actually have this machine sitting in their office and helped us actually do this in practice and hosted me and like did live debugging sessions, and all the other folks who built the kind of key infrastructure to make this kind of work possible. And the other piece of advice is it's always easier, at least I think it's easier, to write more code to take things out of manual steps of other teams, to make this as easy as possible on the other sporting teams who have plenty of other things to do outside of the study. And that's it. I'm happy to take questions. Thank you.
Thank you. Okay, I see a hand in the back. Please, if you can come up to the microphone just so we can get this recorded. Perfect.
Hi, great talk. So you talked about the thyroid test. When do you administer that? When do you give that test to the patient?
Yeah, so in this context, we're using an image-based risk model that just takes the mammogram, and we showed in all of our previous work that this outperforms the thyroid model across every threshold in general. So we're not using the thyroid model in the study at all. In the original validation, we compared against it. And we found that the image alone is more accurate than that across every setting.
Because I was thinking, like, if you administered that test before the patient came in, and maybe based on the results had a genetic test, then you incorporate that in your model, it might have more information.
Yeah, so we've looked into like how complementary is both is the clinical risk factors to the image, which would have its own kind of workflow burden to be able to collect that in the first place. The answer is it barely makes a difference, and it's not really worth the effort. Other folks have explored how much is adding PRS to the risk model to the image make a difference. The answer is also barely. And so you're like in AUC terms, you get like you go from 75 to 76, just like eh. And so for this, especially for the context of this study, which is really empowered by the detection capability of the model, Having something that is really like no new information, just a little bit more code to make a new workflow possible, felt like the path forward.
That explains why the genetic testing companies are not doing well.
Yeah, at least not for this use case.
One more question here.
From the data scientist point of view, which index did you use to check for risk assessment? Did you just use AUROC? Did you try to balance sensitivity and specificity using Jordan's index? Did you use a combination? Did you use also additional, efficacy factors? So what were your parameters?
So I'll give the answer how we thought about risk models in general. So risk models support many use cases. And so the original steps and where it's looking at like guiding model development was RC AUCs. But we also looked at individual use cases. And for the use cases and their constraints, what's the relevant performance metric? In this context, the rate limiting factor for same-day assessments is workflow. So you're only going to do sub 10% of the setup at all to offer same-day assessments. So that was the kind of cap of what the recalls could be. And then given that cap, what's our sensitivity and how many people could we help? And so that was the evaluation setup for this workflow. We have another study focused on high-risk MRI, and that has different metrics for that workflow and operating point to make sense there. RCAC is only useful like pre-picking decisions. We have many decisions we're interested in, and we studied them independently with their own metrics.
Yeah, do you make a combination of precision recall plus Jordan's plus AUROC? Do you try to balance, and also from the patient's perspective, so how?
The constraints of where the operating point is really defined by workflow. So it's not like, how do you balance sensitivity and specificity? It's like, your specificity number has to be this. Yes. What sensitivity are you going to get? Because the workflow defines what that threshold can be. Okay. But that's kind of, it's not really specific. It's like our callback rates can only be some number just to fit within the workflow. And talking with Maggie, that was going to be about 8%. And so that was kind of the threshold. And like, given that, what sensitivity can we enable? How many people who will eventually get cancer, how many Bayard zeros will we make their life better?
Okay, and do we have federated systems? How do we balance, or how do we enable the ethical part of it so that the privacy of the patient still is maintained in these AI systems?
So on the privacy side, this is something, both security and privacy is something we work closely with IT team to resolve. Like the machine that we added, both has all of both UCSF and SFGH IT security stuff on top of it, but also stores no data. So it goes directly into, like there we defer to our colleagues to tell us like, are we doing the right steps? And it's part of the value of all the different approvals you go through to make sure we're following the right process. So the kind of short answer is that we're not storing any data on the setup at all. All we track is enough information to share to the CRC to actually consent to the patients, their data being used, they're consented to even participate in the study. So like that all follows standard practice.
Thank you.
Great, thank you. All right, we're going to switch gears for our final presentation. Much of what you've heard today is all the work that it takes to get a model into clinical practice. And now we're going to talk about the infrastructure that's in place to think about monitoring these models on an ongoing basis, because all of these smart people will move on to their next model at some point and then their next model. But we need to ensure that we have the infrastructure in place to be able to track the ongoing performance of all the models that are going to be left behind, so to speak. So with that, I'll turn it over to Jinoos.
Hi, everybody. A pleasure to be here with you today to tell you about AI monitoring and research at UCSF. And I speak to you in my role as the Executive Director of AI Monitoring in Clinical Care. So Sarah Murray mentioned Impact this morning. I'm just going to tell you a little bit more about it. So Impact is creating a real-time automated platform for AI monitoring at UCSF Health in collaboration with Julia's division, Doc IT. And I think our CEO said it best. This is the first partnership between UCSF and UCSF Health on AI monitoring. Together, we are uniquely positioned to create the first effective model platform across health systems in the US that will offer real-time visibility into AI tool performance and clinical impact. So this is really our goal. So why was Impact developed?
many of you know that we are entering an era now where AI applications actually fall outside of traditional regulatory frameworks. Just as an example, the AI scribe or ambient listening technology that we're using in clinic now is not really considered a medical device, and there really isn't sort of an FDA framework to approve such a product. And there are many examples like that. So monitoring is left to us. We need to be able to assess whether these tools are safe, whether they're equitable, whether they provide value for our health system. We need built-in escalation criteria so that we have timely human review when interventions have problems, and really to help actually our health system decide whether they want to scale something, whether it needs to be refined, or whether it needs to be discontinued because there's a better product out there or because it's actually not sort of meeting our benchmarks. This is the impact leadership team. I just also want to call out Sarah Pollitt, our program director. She's sitting here in the room. But really, this is a partnership between the health system and researchers at UCSF. And Sarah Murray mentioned this morning that, you know, a lot of what we're doing here is experimental, and it's so fortunate that we have a generous donor who has the vision to support this activity, some of which is on the research side. So what is the impact platform going to contain? Well, dashboards are a key part of what we're going to do. We want to be able to track AI metrics for things that are deployed enterprise-wide. We want to be able to visualize some analytic information. But a lot of the work that Hossein and our data science team are working on is really critical too, making sure that all of these systems talk to each other and that we can automate as much as we can. You know, transparency and ethics is really important, as we heard about this morning. And so part of this is just making sure that we can explain to the doctors, the staff, the patients that get care at UCSF, which models are deployed and how do they work? Where does the data go? People have a lot of questions, and so being able to provide that information is important. Reporting and analytics. And then I would say that, you know, coordinating across a complex health system is also a really key thing. There are many models, there are many people working on this, and so just making sure that everybody is aligned is critical. One of the core functions that we've been working on in the first few months of the project is developing metrics. And I love developing metrics, and this has been great fun for me. But we want to develop standardizing ways to quantify accuracy, safety, fairness, and the impact of these tools on physicians and patients. And the process that we're following is listed here. So we're going back to the literature, but for many of these things, there actually is really a nascent literature. And so that is why it's important to also have consensus processes. So we're bringing together our data scientists, our clinicians, our researchers, really experts across the health system in order to decide what we're going to measure and then implement the measures in the impact project. And I just wanted to show you some of the initial dashboards. And again, this project is very early. So this first version is mostly looking at utilization for the ambient listening technology. You can see that about 1,800 physicians at UCSF were eligible for this initial AI scribe implementation. 50% have signed up. And the user retention rate has been very high. Once people start using it, they continue using it. You can see actually here is some data by specialty. We have some specialties that are using it a lot, like cardiology and general internal medicine. And we also see in that middle column that the retention rate is really high. So once people start using this, they like it and they continue using it. And this is actually, you know, I think an important key metric to follow. We're looking at a lot of other things, things related to safety, things related to how this is impacting physicians, and those will be part of future iterations of the dashboard. One of the really key things about this is that, as we run our consensus processes, sometimes there are things that people think are incredibly important to measure, but we don't quite have the tools yet to be able to measure those reliably. And being able to kick this back to our research community here at UCSF, which is so deep and so thoughtful to actually develop some of those metrics more so that they can go into, a live platform eventually, has been part of this. So just as an example for AI scribes, there's been a lot of concern about the possibility of automation bias or the tendency to rely on automated systems, which might lead to errors. But how do we actually measure that? We really need a scientific foundation and sort of the data work to be able to think about what a metric should be. So that is being worked on by a research team right now. And hopefully, as we make progress there, that will enter our queue. So what has been the hardest part of the project so far? Many teams in the health system are involved in selecting AI, implementing AI, monitoring AI, determining its ROI. And so one of the key things is really to prevent a chaotic monitoring environment where everybody's sort of measuring different things. So what we're trying to do is really bring everybody together and decide on a unified set of metrics so that we don't duplicate and waste resources, and instead we sort of really focus in on the things that we all agree are important. Another key thing is that AI tools change very rapidly, and some of the tools that we're using are developed by outside vendors. And so we don't always know when they're updating their models. And so close collaboration with vendors is needed to understand when these things happen. And then, there's very little prior research. There's very little regulatory framework to guide the work. We really need rapid innovation on the research side, on the regulatory side. And that means that there's lots of opportunity for people to do research, which brings me to sort of my last point. We would love to collaborate with those that are interested. We have started a new committee, the UCSF Health AI Research Coordinating Committee, or UHARC, to really assist researchers access data related to AI implementations. We can provide data that live outside the EHR for some of these implementations, connect researchers with projects and with collaborators. And we're trying to develop tools just to make it easier for our community to access the data related to these implementations. Like, for example, fact sheets about the types of data that are available, fact sheets about instructions on how to actually find this data in Epic or in Clarity so that people can really accelerate their research. And I just want to thank everybody pictured here who's been working so hard on this project over the last few months. This has been an incredible team of leaders and data scientists and program managers who have been working on this. And I'll stop right there. Thank you.
All right. Well, with that, let me thank all of the panelists. Maybe we can do a standing ovation also just because we're an hour into a 2-hour session. So join me, get your blood flowing and some clapping. Excellent. Okay, so here's the plan for the second half of the hour. Since you're standing already, if you have a question, please make your way to a microphone. My takeaways from this morning is that I now feel much more empowered to do this work because the panelists did an excellent job of explaining how the work actually gets done. What are the key challenges? What's the infrastructure used? But I also think that it's feeling a little intimidating, right? You heard about projects that started in 2017 or 17 regulatory steps. So the goal really in the next hour is to have you be able to come and ask your questions so that you feel like you can take the next step if you're interested in doing this work. So please come up to the microphones and we would love to take any and all questions. As you are making your way to the microphone, I will, oh no, we have, you're going to be our first volunteer. You're right there. Perfect.
Hi, thank you so much. Those are really inspiring stories. My name is Christina. I'm a future nursing PhD student starting here in the fall. I'm wondering if you could speak to how you gathered that frontline engagement a little more and what kind of change resistance you might have faced from the frontline MDs and nurses involved in having to use these processes.
So the specific question you're talking about, like deployment at the point of care, or you're talking about buy-in from like health system leadership?
At the point of care, those that are actually using what you're implementing. So there's more work to do, right, in their paper charting or
Yeah.
the end user experience.
Yeah, so I think that's a great question. If your intent is to deploy these models in the clinical setting at the point of care. So, so what we did, so we use a lean implementation framework. And so that starts with what in lean is called humble inquiry, where you go around, you ask people, you know, what is your workflow? How are you, you know, outside of technology, right? Because I think the first question is, what problem are you trying to solve? Is there a solution, technological solution, an AI solution for that? And I would say that if there is, you know, it should not be the opposite. It should not be, I have this cool tool and I want to implement it and see what happens, right? That's the first thing. But we ended up doing a lot of humble inquiry with our end users. And then we did collaborative building. So as we developed our tool, we had subject matter experts. Like, for example, we brought in residents who were going to be the primary users of the tool. That navigator that I showed, we actually put in a lot of non-AI pieces. Like, for example, we built a way for the essentially Epic to pre-round for the residents. So they wanted to go to that area of the EHR to interact with the tool, right? Give them some carrots to go to that part of the tool so they were more likely to use it. And then I will tell you now more what we've evolved into when we do implementation. So for example, we've converted this tool to an outpatient tool and we're deploying it in a cluster randomized RCT into the various health clinics around San Francisco. We do a lot of like facilitators and barriers, implementation science, like interviews with the end users. And I guess the last thing that I will say is, I think these tools, it's very context specific in terms of how they're utilized. So for example, we have really high uptake with our inpatient tool. About 70% of users like interact with the tool. We're seeing much lower interactions in the outpatient setting. And there are much different reasons why a user would or would not interact with a tool in a different clinical setting. Also, the type of information that's surfaced. So for example, people are much more comfortable titrating medications than they are making a recommendation for a patient to get an implantable defibrillator, right? The difference between a medication versus an invasive procedure. So I personally think, as I mentioned, like we need more frameworks to understand how to do these deployments because it is very much context specific, and one solution in one context might not work in another context.
I just want to echo what Luke said about getting feedback from the people that will be using it. So, and early in development, we did focus groups with nurse anesthetists, residents, and anesthesiologists early with our initial design, actually the designer sitting in the room, and we completely changed our design as a result. And also, we changed our threshold. We were going to go for a high sensitivity, and then we found out that this would be very annoying to people if it had a low positive predictive value. So we chose a low sensitivity, like 40%, and a really high positive predictive value, so that when that triggers, they know this patient is very likely to have kidney injury, and you really should do something about it, even though the intervention is, you know, not super high risk. So that was really helpful.
I'll echo that kind of end user engagement from the beginning. I mean, for us, Maggie, who is fortunately can't be here today because she's in a regulatory meeting across our other trial right now. She reads mammograms at SFGH. She knows the work. She knows all the people there, and so this wasn't like a idea that kind of came from the outside. She suggested we do this, and then so in that sense, like the context really drove the study from the very beginning. And because she's so deeply integrated, she like has been able to build the support for it internally. There's lots of really great radiology colleagues have helped out and kind of volunteers to help run the study on more days. We're just started just 1 day a week. And so that kind of deep engagement from the beginning is, I can't imagine how this would be possible without it and how we would have thought to work on it. And so that kind of like key leadership from the beginning is critical, and I'm yeah, grateful to have great collaborators.
Thank you very much. I have two questions. In terms of what you see implemented for AI at UCSF, how much comes from within and how much comes from outside in terms of researchers from other institutions or commercially available solutions? And there's probably a component of like how we trust like what's coming from the outside also, but I don't know if you could talk about that. And the second question, maybe Janice but whoever would like to answer. And the second question, what would be your predictions in terms of like all the changes that are going on in the country with what's going to happen with AI, or which directions do you think it's going to push things for AI in healthcare, broad level, as we're embarking on this?
Hossein, do you want to start with the first question, just about sort of the mix of types of tools?
So in terms of from the health system perspective, Epic, our EHR vendor, obviously has a lot of AI tools, and because we already have Epic and their tools are much easier to turn on, validate, and sustain, that's a natural choice. We look at those tools first. If they meet our standards, then it's a lot easier than building something internally or bringing another vendor. The next tier is looking at other solutions out there. If something already exists, then perhaps there's no need for like reinvesting in that R&D to build something internally and have to maintain it. And then the last bucket is kind of like unique solutions, that there's unique problems that there's no solution or no good solution out there. That's something that the health system sometimes invests resources in building that tool. But also we partner with researchers. Some of them are on this panel. I believe there was a mention of AI pilot proposals this morning. That's also another way of like bringing research tools into the health system. I would say those are probably more like for unique problems. A lot of the solutions take time for research, and there's like there are many factors that go in that make them probably less efficient than just bringing a vendor, but it is something that we're excited to support, and also it helps us with addressing problems that there is no solution for them.
Great. And so how many researcher-led tools have come through the UCSF Health AI oversight process to date?
So I don't have a good sense of imaging research tools. For EHR-based tools, there are, I want to say, 4 or 5, but they're like at different stages of their process. A lot more in the development phase that I know of. But of those that have gone actually through some AI oversight process, either in silent study or pilot, I would say there are probably 4 or 5.
So maybe to transition to your second question, I mean, it's still early days, right? If we've seen, really a relatively small number of tools overall, 4 to 5 research-led tools. So maybe the panelists could comment on, do you expect that this is really going to take off? Like, can you imagine doing 4 or 5 or 6 of these projects over the next 4 or 5 or 6 years? Like, how do we will we, and like, how might we increase the pace at which we do this work? Yeah.
I just want to make a quick comment because I don't want to shortchange all of the amazing work that's happening in imaging. Imaging AI, I would say, is more mature and this has a longer history than we do with a lot of the EHR AI work, honestly. And so our radiologists before we built an AI oversight committee for the health system more broadly, they had built this for imaging. And so they have we actually send all imaging multimodal solutions to that group, and they have had a lot of research tools come through. So I just want to make sure they're doing a lot of really innovative work. And so we're very EHR focused in this panel, but There's a lot going on there. And if you have multimodal or imaging research projects, it can come in through the same queue, but will ultimately get reviewed by the people who have expertise in imaging specifically.
So I think Julie posed an interesting question that how do we pick up the pace? And I'll tell you, frankly, imaging does have a process in place, but an EHR is really important to imaging. I think one of the things is really salient is the time and the number of signatures it took Adam to get to his point. And that timing that it's taken, it's absolutely extraordinary. So Adam was very persistent and had a really great partner. But none of this is actually documented in a given place. And it has taken some tools to be deployed in the imaging pipeline, even for evaluation up to 2 years. And I think that really is a roadblock within the system. It's not something that cannot be solved. It can be solved. But I think we've also spoken to Sarah before. I think Chris, as our chair, has actually brought this up, that it takes months to get this going. And some of the things actually need to be evaluated in depth because they're going directly for patient care and it's going to impact the patient directly. But so much of it is early on, validation, decision support, randomized control trials, all of those things, when it takes 2 years, there isn't a single physician scientist who can actually navigate this in a reasonable way. So I think from our perspective, that would really be the key case, and that really needs to happen.
Great. So maybe each of you can just speak to, like, what do you think are the key levers that would help speed up the work from perhaps an efficiency perspective, or if there are other things that you think we could invest in that would allow us to do this work more quickly while still maintaining the rigor and the trustworthiness?
So a couple of things. I'm on the health system side. I'm speaking of like experience interacting with a lot of great researchers. A couple of things I mentioned. One is partnering with operational leaders, clinical leaders early on when you think about building a tool. Sometimes what we have seen is like people go in their own lab, build a tool that is great, but when they come to actually thinking about the implementation, they may need to redo certain things or think about the problem differently. So how do we like build partnership early on? I think that's super critical. Another thing, perhaps more technical, is thinking about like access to standardized data. There are a lot of great resources at UCSF already, Information Commons, other places to get access to data. Usually what we have seen from experience is that there are a few important steps on top of that to get that model into actually like a production environment that you can implement. So that's getting access to some kind of a standardized data. So you have to minimize the amount of like data cleaning, processing that you have to do, each researcher have to do. I think that's key. We've talked with some folks on this panel about this, and there are some ideas with early discussions about it happening. So hopefully that will help as well.
I think to speed up projects, one, just understanding that some of these things, research takes time and you need patience. And whatever timeline you project, probably like double or triple it. But I think things are moving along faster. It seems like the AI pilot that's going to be coming up will hopefully speed up a second round like proposal of pilots, because I think a lot of the AI machine learning heavy lifting will be done by experts as opposed to like a single PI. But that being said, I think one thing that helped speed up my project was receiving one of the first AI pilot award grants, which put my project in the lens of like the key leaders at UCSF that wanted to see this project move forward. So I think, pushing more resources to people with ideas is like the best way to go.
I would encourage everybody to think about what is the return on investment for the health system for what you're doing. I think it is challenging as an individual PI to, have a research idea that may or may not be in concordance with what the health system's priorities are. And that's not to say that, research has to, research should not always necessarily be in concordance with what the health system wants to do. But I think increasingly we have to think about, doing projects that the health system is going to find value in, and there's going to be very clear return on investment. And I think increasingly that is, financially, because a lot of resources obviously are being invested into the infrastructure to build this stuff. And I think, nationally, there has not necessarily been a big return on investment yet. So I think, for us at ZSFG, we can only do projects that have clear return on investment to the health system. The other thing that I would say is, I think that there is obviously not all AI is equal. I think in my mind, there's a difference between some of these sort of assistive technologies, like ambient scribes, right? Like there's clear implementation. It goes into the health system. It's pretty straightforward versus deploying at the point of care to try to impact clinical workflows, and that is a heavier lift with much more sort of regulation, and governance that needs to go into that. And lastly, I would say I would caution, just to go back for a moment, I would caution the use of proprietary models. We looked at a lot of proprietary models for some of the work that I do at ZSFG. They do not perform well in our health system, right? The idea that a model that is trained on 3 health systems in the Midwest, which like a lot of the EPIC models are, is going to perform well in a safety net population, urban safety net population in San Francisco, it doesn't perform well. So although I think it's easier to use proprietary models, I don't think we're in, we have a lot of data now, and there's a bigger lift to develop our own models internally. But I think we owe it to our patients, especially if they're going to be deployed at the point of care, to have models that really perform accurately. And many times that means custom models, or what we are starting to do, which is partner with other safety net health systems and maybe share models across like health systems.
For me, I'd say kind of the smoothing of the process from development to production. And if there were a way to kind of push that development process a little bit further before you have to start spending a lot of money on production, can get rid of models that don't do well in prospective validation early. And you really want a high iteration testing removal of models that don't do well early. So kind of what Hossein alluded to about the mapping of variables or figuring out ways to have a development environment, I think would really help us.
On the imaging side, I really think we're positioned to be building the best AI tools that exist. We have many commercial vendors you see in the space have less data than we have in isolation, not even counting the other UCs that can collaborate together. And our tooling across, I've been here for 2.5 years so far, the core infrastructure to make this kind of research possible has gotten a whole lot better. And I think will be not so much model development bound, not so much data bound, but really translational bound for the time to come. And we'll have to be strategic of, we can only go through so many individual processes at a time. We'll have to be strategic which things do we want to prospectively try to translate, because we'll have more tools and we have bandwidth to go through regulatory for. And so at least on our side, I would think, I'm very pro, we need to do this safely and ethically. And I think the full set of committees that we have is very valuable, but there's probably opportunities to do some merging here and there, at least make more of them parallelizable, have a joint submission process to make that end-to-end process a little bit less of a maze, because for us, that is the hard part. The setting up collaborations, finding the right problems, that's a natural joy of academia. Collaborations is the fun, easy part, and building things and innovating and how we build, we should be ambitious that we can build the best things that are out there. It's deploying them that is currently the tricky bit.
Thank you. And just, so many good points have already been made, and certainly there's room to increase efficiency so that the time is shorter. I also think that, for the trainees in the room, though, the reality is that implementing an AI model in a health system is big. You know, it's like you should think about it the same as running a multi-site clinical trial. It's not the first step. You know, I think you really need to start with maybe a retrospective data analysis. Come talk to me, use some of this impact data, start working on your model, and have a realistic time frame that is going to take into account the fact that it's going to be complex. And I think no matter how efficient we make the process, there are going to be regulatory issues and committees and workflow issues that are going to make this time consuming. So just, plan for that.
Hey everyone, thanks for the great talks. My name's Andreas. I'm from radiology as well. One of the things I want to bring up on the point of efficiency is, of course, we've talked a lot about regulatory and how we can make that more efficient, but one of the issues that we face is also just data access. And in imaging, on the imaging side of things, as was alluded to, we have some systems in place to be able to access, large swaths of data under IRB approved research studies pretty efficiently. And, no system is perfect, but it works pretty well. I was wondering what the barriers are to making EHR data more freely available to the community, because certainly I'm sure there's many more ideas than can possibly be tried out, and one of those barriers seems to be data access. So what are the specific barriers to that, and what are we doing to overcome them?
I can start. I would say that the situation at UCSF and at ZSFG is different. The data access for EHR data at UCSF is pretty good. If you want to start with a de-identified data set, you can get started right away. If you're interested in working with identified data, just going through an IRB and being able to access data that way is possible. You can work with academic research systems to pull a data set for you. We also now have this federated broker model where many departments actually have a Clarity programmer sort of embedded with access to the EHR data. So I think the access to EHR data really should not be a big barrier at UCSF. At ZSFG, we've made some progress, Elaine Kuhn and others, to create a de-identified data set that people can use, but there's still a lot more work to be done there.
Maybe we can also comment, because I think one of the things I heard two panelists say is that the transition from working with retrospective data to prospective data was a challenge. And it sounded like the key challenge was not knowing sort of lags and when data become available in real time. So I guess I'm curious, is that a piece of infrastructure on the data access side? I don't know if, Andres, this is what you're getting at, but where specifically we could better understand what the prospective environment looks like before we get there, or should we be speeding time to working in the prospective environment?
I'll touch on that. So prospectively being able to you can do repeated calls of a Clarity thing that you have, or you can look at the granularity of when that information was put in, and then you do a lot of complex programming to figure out, was this put in at the time of prediction or after? Is this leakage or not? So that can be customized, but it's a lot of work to do yourself. And I've both done it with the health system and have started to do it on my own. I'd say it's a lot better to do it with the mapped variables that they have. But it would be great to use the mapped variables that they have for the actual development. And I know that's kind of in the pipeline potentially. I don't want to speak for them, but that would solve a lot of problems. So maybe I'll pass it to Hossein.
Yeah, I think as you're probably aware, Information Commons is a great resource, but it does require a few extra steps to translate that to what it would mean in actual practice. Mapping these variables and defining these standardized variables is actually one of the things that TypeAct does. And we have been providing that as a service through Apex-enabled research to researchers who want to bring their tool and implement it in the health system. However, what we're realizing increasingly is that we can add more resources to our team, but there is a great demand for these things, and it's just not scalable to have one place that people come in to get these resources. There are early discussions about like making this system available in some form or fashion in information commons in a de-identified way for researchers, so they can, one, utilize the standardized variables for retrospective validation, model development, and also like one step further is having some kind of easy way for folks to do a simple version of silent study or perspective validation on their own, so that to know what data is available when, if the model is good enough, and then once you're confident a little bit that this model is valid, then you can come into the queue for bringing your model into through the oversight process, through the governance process, and implement it in the health system. So there are early discussions about this. I would say there's increasing awareness of this need. I think that there are conversations going on about prioritization and budgeting for this.
Hi, I'm Joan Hilton. I'm a biostatistician, and I want to talk about a general problem by starting with an example. So I'm pretty deeply immersed in a prediction modeling exercise for diagnosis of pulmonary arterial hypertension. And I'm finding from the literature that the relevant predictors are coming from echocardiography, ECG, CT scans, MRI, but we're relying on clinical data. So all providers do not request all of those tools to be used for all their patients. So there's no opportunity for comparison of which ones are more predictive than others. And I just wonder if there's a possibility of sort of per diagnosis to define a common set of metrics that would be billable and collectible in relevant patients. Because you guys are mostly focused on access to EHR, but it's like, what's in the EHR? So driving the EHR data collection by what's really needed in order to answer the question of, actually, you only need a CT scan in this case. You can't address that question unless you have all of the opportunities to compare them. So, my beef.
I mean, I think we've used the EHR because it's the most convenient source of data, but it is not all the data across the health system. So I think increasingly there needs to be a movement towards integrating various data streams into models, right? But the challenge is you need systems like HiPAC and computing environments that can integrate multiple data streams, for example, this is what this patient's, MRN is in this system, and it's different. You got to map all those things together. So there's no question that is the future, I think. And it's not just, it's imaging data. I mean, you can imagine all sorts of data that could be integrated together. But I would defer to Hossein. I mean, that is a huge lift to do that. I would also say, various EHR systems have different access to data. So I'll tell you, I have a couple of projects that cross UCSF and ZSFG, and like where echo data is stored at ZSFG is different than where it's stored at UCSF. It's actually stored within the EHR at ZSFG. It's not stored within the EHR at UCSF, and that creates problems when we're trying to deploy models, across sites. So I agree with you, but I think generally, with the research that you're talking about, I mean, there's always going to be missingness in data, right? Regardless of the project that I'm involved with, there's always a tremendous amount of missingness. And so, I mean, the best way that I have seen people accomplish this is prospectively, enrolling patients in trials and just asking to collect data as you go. But that brings up its whole other challenges. So I don't know if you're necessarily going to be solve the missingness. Hopefully one of the more data science focused people can describe integrating multiple data streams, but that's definitely needed to advance the field forward.
I'll add from the cancer side, this is kind of like a fundamental thing, because like all the interventions that we do in practice are really multi-step. there's a big tree of like, first a screening mammogram, then something else might happen, then something else might happen. And part of the research is how do you understand, how do you make that decision tree better and how you sequence those modalities? And in that sense, if you think about the overall cancer screening paradigm, you have to start at the EHR, which is like, who do you screen even in the first place? So like one collaboration we have in Denmark is how do you pick one, like, how do you help people who are getting diagnosed outside of guideline, women before 40 or people in pancreatic cancer? That's fundamentally an EHR model. Once you have that, especially in the harder settings, which image modality is more effective at that population? That's a trial, we don't know. And that's a trial that UCSF participates in called Proceed. And then given you have that, how do you make that next decision better? So all of that I think is like already within the kind of same research bucket of challenges that we already think about as a community. And the challenges in integrating any one of them kind of come back to the same challenge we've discussed on the panel of like any imaging type of tool has the same challenge to kind of get out the door. Any EHR tool has the same challenge to get out the door. And so I'm hopeful that as we tackle those, it's going to lift all boats, regardless if you're tackling one-step intervention or intervention tree.
And I'll just add one small thing that we haven't really brought up on this panel, but is really important. You don't need machine learning. So like really, if you can do your model without machine learning, it's a lot better because it's more interpretable. It's clear what's going wrong when things are going wrong. It's easier to monitor. So there's actually experts that do high stakes machine learning, and they advocate for rule-based, simple tree-based, or logistic regression. So if you can, try your model that way. And often a lot of the things like missingness, you can find the only the variables that are necessary and just do your entire model that way.
I'll just make one more comment, which is that I do think that we are moving, at least in my field in rheumatology, to creating sort of a minimum data set to be able to apply models, or to compare outcomes even. And so I think there needs to be work at the national level through professional societies and other things to actually define what a minimal data set is. And that's going to change with AI.
Yeah.
So your point is very well taken.
And just to add one more point about machine learning versus regular modeling, many of these metrics that I'm talking about are extremely highly collinear. And, they have a lot of redundant information. And machine learning, its great contribution is to find within them the orthogonal pieces that uniquely contribute to the prediction. And that's something way beyond the human mind, especially when there are, I have like 90 echo variables plus, within each of those domains, just a huge number of variables. So teasing that down to an important set is the challenge. Thank you.
Just add one thing to that. A lot of times I'll use machine learning to find the variables that matter, and then the actual implementation is something super simple. But I totally agree with you that it's powerful and we shouldn't not use it.
Thanks so much for this great panel. I'm Courtney Lyles. I had a question. Many of you talked about collaborations, focus groups, interviews that you were doing specific to your research, and then especially for the individuals working at ZSFG with smaller IT teams to build or implement models. I was curious if you could get into the brass tacks a little bit more, especially for people who haven't done that, about how much budget you spend on that, how you create your teams, a little bit more insight on how you do that, because to do this, especially in the implementation phase, less in the discovery phase of your models, talking more in the weeds about that, I think would be great.
So for the blood project, we collaborated with the Apex enabled research team, which has experts with like PhD level understanding of like the design process. And they, and I was very new to all of this too when I started that, the planning for the implementation part. And the Apex enabled research team had a few designers that they assigned to my project, and they're the ones who walked me through the steps of what's required to design a intervention in like the EHR. And the first part was just story mapping, or like doing the storyboard of just the whole, what's the current process of like ordering blood at UCSF in the peri-op period. And they were instrumental in conducting interviews with me to just understand what's the process. And then their design folks like put together the storyboard of that. And then they also helped like figure out the questions that we would ask like the residents or the nurse practitioners, anesthesiologists, CRNAs on what their current practice is and what they want in a design and what they would like, what they wouldn't like. So I think relying on experts like that is really valuable, because my expertise is in like data science and anesthesiology and clinical informatics, not necessarily design. So I think that was like a great resource that UCSF has to get that process going.
So at ZSFG, the lab that I co-founded and now run is really came out of COVID, in the sense that all the modeling that was done for City and County of San Francisco and the Bay Area was a lot of hospitals and health systems contributed to that, and the people who ran the COVID command center, many of them were executives at ZSFG or NDPH, and so coming out of that. Coming out of the pandemic, there was a desire to use data science for, to improve health outcomes, specifically in underserved populations. So the grant was, or sorry, my lab was started with philanthropic funding. We now, get grants to continue to support the lab, but we do have ongoing support from the health system and from philanthropic funding. It required, like, I have a very, very, talented, group of individuals who I work with, like Jean Fang, Omni Kothari, Patrick Fossler, who are data science, my data science dyads. And so it costs anywhere between like 500,000 to 800,000 a year to run, a team like that, which is why, if you ask me, like, what is the most important thing, in terms of getting your projects forward, like for us, it is to partner with our health system to return, what they are investing with us. And I think that, again, increasingly, I don't want to, I want to differentiate a little bit research from, health system priorities. But at the same time, we have to consider the realities of how much it costs to do this, the expertise. And so, again, if you can collaborate with your health system leadership, and provide value, increasingly, again, in this environment that we're all aware of, I think that is what's going to make people more successful. And I would say to, more junior faculty and trainees, maybe you don't, maybe you have to adapt your project a little bit to make it in line with health system priorities, but you're going to have a much easier time getting your projects done, getting your approvals done, getting support from the health system if they are in line with the health system priorities than if they're just an individual wanting to pursue their own individual line of research.
I can't help but jump in here just very briefly to say that that many of the people who organized today's conference also put on a monthly webinar called Evaluation of AI in Real-World Clinical Settings. So if you're interested in an ongoing discussion about many of these topics, I encourage you to join that webinar, which is open. Our last speaker was Vinny Liu from Kaiser, and what he described is that we have data science, and what that needs to be partnered with is a notion of delivery science. And I think what you're hearing today is sort of some of the bones of delivery science, but I would maybe love to hear the panelists say, do you think that there is this concept of delivery science? I mean, Courtney, I think your question to some ways is like, is this a science? Like, how do you know whether you've gathered enough data from your users? How do you know if you've done a robust workflow implementation? Like, does it feel scientific, or is that something we need to work towards to really define this science of implementing AI and then actually build up experts who are delivery science experts?
I guess my question for you, Julia, is how do you differentiate delivery science from implementation science?
Yeah, I mean, I think that's a great question, and maybe they are like I think we could conceive of them as the same thing, but I wonder if some of the issues we've talked about today, your traditional implementation scientist wouldn't necessarily have thought about. Like I think a lot of the implementation science frameworks maybe aren't specific enough to some of the issues we've talked about around AI to be useful, but I think other parts are. So maybe it's articulating what the gap is between implementation science and what you need to do AI delivery science.
Oh, yeah, no, I very much agree with that. So for example, why do we use Lean as one of our implementation frameworks? Because, Lean was developed, as a manufacturing, efficiency, process. But what we love about Lean in our lab is it takes into account automation, right? A lot of what we talk about with this technology is how do we, automate tasks? How do we improve efficiency? And so built in within Lean, there's like some basic tenets about how to, combine humans with automation or humans with technology. So we really like that. Lean has not been as successful for us in terms of actually understanding like deployment characteristics and what's going on like in the individual clinics. And so we've relied more on like implementation science techniques. But I 100% agree. Like whether this is a combination of a bunch of different frameworks or whether this is a new framework, personally, we have not felt that there is one particular framework that has been in and of itself useful to allow us to do these large scale deployments across the health system. So I think that is a ripe area of research and something that absolutely needs to, whether it's a new field or an offshoot of existing fields. I will also just say, like, for example, like health system leadership tends to think more in terms of Lean and researchers tend to think more in terms of implementation science. So at some point you have to bridge the gap if you're talking about, deploying these across a health system where you need buy-in from the health system and from, the research expertise that you have within that health system.
So I think along these same lines, we see a lot of model development start on the scientific research side and then work its way through with clinical champions, the process of getting to prospective clinical validation and then deployment. Is there, or are there any official or unofficial programs that try and reverse the flow and start at the beginning with someone from the hospital, either clinicians or operations or staff that identify problems, and then they get connected with developers and researchers who work with them to find a solution, and then maybe that leads to more of a willingness to participate in clinical validation studies, put in the effort, and then do actual workflow modification and integration of the tooling at the end.
Yeah, I mean, I think the answer might differ based on the different sites, but like at UCSF, for example, there is a team like run by Ralph Gonzalez and others where there is sort of the opportunity for frontline staff to raise improvement opportunities. I don't think there is a systematic way that those necessarily get connected to this question of like, is AI the right solution for that? And so I think really the way that this has been solved is by the health system articulating its priorities for problems that we're going to do an assessment of whether AI is the right solution for them. And some of those have come from the front lines, but I think others have come from senior leadership. So I think, it's happening in different ways, but I don't think we're quite at the point where this is happening like systematically, where like anyone on the front line could say, I have this opportunity, and then it would flow through. Again, in part just because of like the resource constraints of, trying to figure out whether every problem, doing the pre-work of like describing the problem well enough and then figuring out whether there's an AI solution out there that makes sense.
I can speak for, so I also work at the San Francisco VA in their informatics realm, which is probably like, 1/20th of the size of UCSF just with their local VA. But we also collaborate on national projects. And in a big bureaucratic system like the VA, oftentimes it's hard to take a project from the ground and then implement it nationally, but it has happened. Not too much AI, but historically, like, starting drugs preoperatively or like continuing certain drugs like beta blockers and stuff has had like national effort, which then get rolled out to like, 200 plus clinics or hospital systems in the VA. But just from wearing my more admin hat at the VA, what we are doing is we get a lot of departments that come to us with the problem, and then we'll try to figure out like an IT solution for them. Most of the time, it's not anything super technical like AI, but a few times we have come across problems where we've thought like an AI solution would be the best. And so really that ends up really meeting like key performance issues that the hospital system is having. One actually being recently last year, we've had issues with heart failure readmission too at the San Francisco VA. So like, you know, using your model, I want to talk to you about it later, if we can implement something like that at the VA, because it's like one of our top 5 problems at our VA. But we also have like national projects that you basically need like a national leader championing it who has a lot of clout. I think that's how projects end up getting pushed in the VA health system. I think like the best thing is like, as you had mentioned, trying to find a project that aligns with the health system's goals. I think for my blood bank project, at the time when I submitted, like sustainability in healthcare was a hot topic. There were blood shortage issues like nationally. And, you know, blood is a very hot commodity because I think the majority of blood, or if not all of the blood at UCSF that we use for patients is donated blood. So, you know, just wasting any drop of that is, you know, a problem. And so I think like for me, like that was probably why my project got chosen. So yeah, I think in a smaller system like the VA, we end up doing what our leaders tell us to focus on, or if there's like a big clinical need that we need to address.
My question is that because we need continuous integration and continuous delivery pipelines, and the continuous monitoring is one of them, have you implemented CI/CD pipelines for your models? If yes, what was the challenges, or if no, why? And generally, my question is that in what capacity it is possible to implement CI/CD pipelines in the hospitals, because we have regulations, because we have data security, and these kind of challenges, especially for the healthcare industry.
So from a technical IT perspective, on HiPAC platform, we have CI/CD pipelines. I would say when it comes to AI, the technology, I don't believe it's quite there, because there are a lot of challenges that you have to think about when it comes to promoting an AI model from like development to production. And there are not always easy ways to test it. This is in addition to the oversight and governance process that we have. So as an example, think about like when an AI tool is implemented and you want to retrain it and implement a new model, users already are like used to certain behavior from that tool, and they've built like a mental model of how it will work. And if your new model, even if certain key performance metrics are better, but the behavior is different such that it changes their mental model, that is going to cause a lot of issues. So just thinking about like ideas for research, I think this is an area that I believe there's a lot of room for like more research to understand how we should think about like upgrading an AI tool that is already in production.
Hossein, can you translate this question for the rest of us? I'm not sure I understand.
So CI/CD stands for continuous integration and continuous delivery. The idea is that you want to minimize, from like an IT perspective, you want to minimize the time and effort it takes to, like, when you develop a new tool to take it into production. So how can you automate it? Are there tests that you can implement automatically to make sure that the build meets your standard and then promote it to production? what I was saying was that that standard sort of CI/CD pipeline architecture that we think about for software engineering is not really that mature for AI because of all the unique challenges that AI has.
This is the continuous of this question. CI/CD is mostly possible through the cloud systems, and most of the cloud systems are providing this system. But in the healthcare industry, because of the data security, they are reluctant to share this data on the cloud. And my question and my challenge that I'm thinking sometimes about is how we can solve this problem, and if it is going to be locally, how powerful it can be for a hospital only or for a worldwide hospital. And this is because you have experience of this model developing. It is a good thing to ask from you because you have gone some steps forward, but for the CI/CD that we wanted to be sure that always the model is accurate, we need to have these pipelines.
Great. Thank you. Well, we've all learned a new acronym, so that is one takeaway. But please join me in thanking our incredible panel. Thank you all so much.